Okay, how about this one? You got that on a shoulder film. There are a few clues here. We've got some mediastinal clips. So this patient's had previous surgery. They haven't had a median stenotomy done, so you think, well, okay, it might not be cardiac related this. They've got some surgical clips. We might have loss of volume in the left hemithorax. We've certainly got a pleural-based density. Axillary clip central, so this is either recurrence, okay, of the previous cancer which they had, in this case presumably a left upper lobe cancer or something similar, hilar mass which has been resected. They've now come back with shoulder pain. So this is pleural based. Look how it comes up, the pleura quite smooth, and then you get this lovely smooth curve running up. We've got some surgical clips here. We've actually got clips there, and then again going off. So pleural based lesion. Again, think about the ribs. Can we see all of the ribs? Can we follow them all the way across? Have we got rib destruction? These are the things that we need you to be taking into account, okay? Easy mass, right upper zone. This one seems to extend towards the pleura as well. This is an apical mass. Shouldn't really have any problems with any of these, really. They're obvious masses. It's the subtleties that you need to pick out. Okay, how about this one? Shoulder film. Shoulder pain. If this one came on your pile for reporting, presumably you'll be F5ing out of that and going to the next one. Or maybe thinking, go on, I'll have a go. I'll go and find a nice friendly radiologist or somebody to give me a help. What are the features? What are we looking at here? There's a lot going on. And this was how this patient presented with shoulder pain. Okay, so talk about the bones then. If it's easier to talk about the bones, what's the appearance of the bones? The bones are quite sclerotic, aren't they? The humeral head is a bit dysmorphic. We've not got a normal shape to the humeral head. We've got a large area of sclerosis within the humeral neck. We've got a very sclerotic, sort of moth-eaten looking scapula. It doesn't look right at all. And then when we go into the lung fields, we've got multiple small nodules, sort of miliary, all similar size. So we looked at this and it's like, okay, there's something serious going on here. So we're going to have a chest x-ray. Let's see what's going on in the rest of the lungs. So now this patient has got a chest x-ray. We find we've got a bit of remodeling and dysplastic shoulder joints bilaterally. Both the glenoids and humeral heads aren't right. That might just be a bit of a red herring. We've got a Hickman line or something in this patient's having treatment for something. The nodules are dense. They're of all quite similar size. Some are a little bit larger. Some are quite small. We've got a focal density here, probably a focal density here. And we've also got something going on here along this lateral chest wall. So now you start thinking about the ribs again. Can I clearly see this rib? I can't, can I? I can't make out that rib at all. I can probably make out this one, probably here. At a CT chest, so we've got this destructive rib lesion. These are multiple miliary metastases, most probably throughout the lung fields, and we've got skeletal metastases. They stuck them in the bone scanner, and there you have your answer. So we've got all the sites indicated that we were looking at, and then we've got this right hemipelvic lesion as well, very hot on bone scan. That all started with the plain film of the shoulder, and you follow them through them with the findings that you get, okay? In terms of densities of the chest, so talking to you about how the mediastinal structures will move. So if you get consolidation, you get collapse of a lung, then what that will pull the trachea towards the side that's collapsed because you're losing volume and the trachea will move. This is a patient with a large pleural effusion. And this pleural effusion, it's tracking up the lateral chest wall, probably almost to the apex on this AP film. So there's many, many litres of fluid within here. If you want to sort of lose a costophrenic angle, you're looking at a couple of 100 mils of fluid. You want to pacify a whole hemithorax, it's litres of fluid to do that. This patient's probably got 3-4 litres of fluid within this pleural effusion on the left side of the chest. But the net effect is, due to the increased density, the fluid, it actually is pushing the mediastinum across. So you can see the trachea is deviated to the right now. The whole mediastinum is pushed over to the right. The right lung is doing its best to do all the gas exchange for the patient. We've got a tiny bit of aerated lung at the top. So tracheal position will tell you whether it's being pushed or pulled, whether it's consolidation and collapse, or it's effusion, which is pushing it over. And these are the subtle signs. Okay, how about this one? Yeah, so we've got left side. Look how nicely we see the lungs. If only we could, see the lungs as clearly in normal life, it would be fine. But okay, left-sided pneumothorax. Collapse the lung if you want a good view of the ribs. Always helpful. But yeah, okay. And then again, mediastinal position. As soon as that pneumothorax gets large, then you start to get a tension component. Then it's going to start to push the mediastinum across. Okay, becomes your tension pneumothorax. Many causes of a pneumothorax, no obvious rib fracture. Always have a hunt round for one. See if you can see an obvious displaced rib fracture. Okay, and then an even larger one. The lung will always go down to the mediastinum. Okay, and it collapses down like a balloon to where it's tethered at this point here. Okay, complete, and we're starting to push right heart borders almost at the level of the lateral side of spine. So the heart is slowly being pushed over due to the pressure within the thoracic cavity on the right. Okay, another one. So you get a shoulder film, you get an APT spine, and you've got this sort of calcified nodular appearance within the lung fields. You can't dismiss it, you need to think about it. Okay, we've got some atelectasis down here, or minor collapse, subsegmental plate atelectasis down at the bottom. We've got a slightly larger density here. There are multiple causes, one of which would be chickenpox. So this would be chickenpox. So this is varicella pneumonia that you'd be looking at. This might be a calcified granuloma. Okay, so it's just taking into account things that are going on within the lung fields. Don't dismiss the lung fields. If they look wrong to you, there probably is something wrong, because you've seen enough chest x-rays over the years to know what a normal lung field looks like. So if the lungs look wrong, they probably are wrong. So you need to be doing something about it, alerting somebody. Okay, this patient has had a chest drain in. We've got multiple fractured ribs on the left side. Probably had a pneumothorax. Popped a chest drain in to reinflate the lung. Extensive surgical emphysema, tracking round to the right side now. Okay, so again, thinking about the surgical emphysema, we have to check the side hole positions. I've got a lovely case later to show you where you have to appreciate the side hole positions in the chest drain. Okay, you might vent the air out from the pneumothorax, but you've got to make sure that you've got your chest drain in the right position. So it's appreciating that. You might have an APC spine with some surgical emphysema. Where's it come from? Why have we got it in? Have they not got a chest drain in? If they've not got a chest drain in, why have they got surgical emphysema? They might have been vomiting a lot. Okay, it might be something called Boerhaave syndrome, where they get excessive vomiting and they get small esophageal tear and they get a little bit of air tracking up the mediastinum. You might see it down by the heart, pneumomediastinum. So again, it's picking out, why have they got surgical emphysema? Have we got a decent explanation for surgical emphysema? Okay, APC spine, what do you think? Are you happy? Opacity in the left mid-zone, yep. Okay, there then they had a chest x-ray. So, okay, we can appreciate the normal hilum, the normal hilar vessels, okay, but this is sat in the middle of nowhere, doesn't appear to be related to the hilar vessels. And there's your lesion on CT. Comes very easy. Taking it back though, easy to miss. Just on the periphery of that AP T-spine image. If the radiographer had coned it any tighter, then we wouldn't have appreciated it. That could have gone undetected. So, yep, good spot, Craig, yep. Okay.